HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
I'll be speaking to Dr. Kunal Verma about Ehlers-Danlos syndromes. Kunal is Australia's first dual-accredited clinical geneticist and cardiologist. He works in both the public and private sector and sees patients from around Australia with inherited heart conditions, including Ehlers-Danlos and other connective tissue disorders. He's the clinical lead of the Cardiac Genetics Service at Alfred Health and the Victorian Heart Hospital. Kunal, thanks so much for joining me on today's HealthEd podcast. Could you tell me a little more about yourself?
Thank you for the invitation and for the opportunity to come and to reach out to such a wide audience. I trained as a cardiologist, got interested in genetics because my father had a heart attack when I was in medical school, and his mother died suddenly when he was in engineering school. So that really got me thinking about, I'm the next in the line, what's happening. And so when I finished cardiology, I decided to dabble in genetics. One thing led to the next. I ended up finishing and training as a geneticist and then managed to find my little niche.
Well, today we're going to be talking about Ehlers-Danlos syndromes, or EDS, which are a group of complex heritable connective tissue disorders with multiple subtypes. So can you tell us a little more about how you came to work so closely with this particular patient group?
I think I came to work with this group of patients by chance, Rebecca. It was not fate, it was not foretold, it was not planned. I ended up training as a geneticist and a cardiologist, and so I'm in this tight niche of seeing patients who have a genetic cardiovascular condition, whether it be blood vessels or heart, and it can run in families, and there's not many other people who can do this. And so they started coming to me looking for answers, and we see them in the public clinic. We also see them in private, but the overall, I suppose I came to it because there was a need, and I managed to be the person only because of my unique skill set, I suppose.
Okay, well, let's get into it. So could we start with you telling us about the different EDS subtypes and their prevalence?
What I want the audience to understand is that Ehlers-Danlos is a group of conditions. It's at the moment a group of 13 inherited conditions. They are all inherited, meaning they all run in families. We can find multiple people in the same family having the condition, especially in the dominant forms. And the recessive forms are also inherited. The parents are carrying it and the child develops a serious form of EDS. Of the 13 types, there are 12. So they're all genetic, meaning they all run in families, right? They're all heritable. Of the 13 heritable EDSs, there are 12 that we can pick up through a genetic test. So you can diagnose it by seeing someone and examining them, but the best way of diagnosing them is through the genetic test. That's 12. And then there's the 13th, which is hypermobile Ehlers-Danlos, which is heritable, runs in families like all the other 12. It's just that we don't have a gene for it yet. So it's diagnosed not on a genetic test, it's diagnosed based on clinical criteria. There is a standardized criteria we can use to diagnose it. And the group is very broad, and the problem with this group is that some of them can predispose to nasty, life-threatening vascular complications. We're talking about arterial dissections, aneurysms, people dying suddenly, women dying during pregnancy, having a gastroscopy, the bowel ruptures, and that kind of serious stuff we're talking about. And often diagnosed after the fact, as you can imagine. They're rare conditions, let's be honest. So I hope that we will talk a bit about the kind of red flags that I could help you all understand are the things where you shouldn't ignore. But I think I must acknowledge also that they're difficult to diagnose. Even as a cardiac geneticist, they can be difficult to diagnose. So, so the GPs take that away, that the onus is not on them to make diagnoses like this.
So were there any sort of features seen across all the subtypes that might alert a GP to the possibility of a connective tissue disorder or Ehlers-Danlos?
Let's start with first, I suppose, the hallmark of EDS, which is hypermobility, which is, for want of a better term, bendy, stretchy. The tall, thin, bendy, stretchy young people, they abound. They're everywhere. Now, I will say that hypermobility is a physical trait. So, it's like height or eye color or how long your nose is. there are 2 billion people in the world technically who would be hypermobile according to the normal distribution of how much your joints should move. I'm on the stiff end, they're on the bendy end. So being hypermobile in itself isn't, a marker of something serious on its own. So we can't then therefore say every single hypermobile person should have an assessment for EDS. But hypermobility is a common theme that runs through all the genetic EDSs, or all the EDS subtypes. So I suppose that's one hallmark. And then on top of that, I'd like the GPs to be aware of nasty, serious things that point towards the EDSs. So the specific things that run again and again in this group are very significant musculoskeletal problems. So beyond just joint pain and fatigue, but also severe scoliosis is one thing. Children having surgery for club foot and extreme weakness, myopathy, very kyphoscoliotic from early on in life, not just childhood, but adolescent years. We have a lot of patients with idiopathic scoliosis in adolescence and having rods put in their back, which is appropriate. But that should be a flag to say, why is this young person's back becoming so scoliotic that they require surgery? That is a flag to say, could this be a connective tissue disorder? Another set of things that are common are vascular complications. We're talking about aneurysms and dissections. Another thing that's common is ocular issues. Ectopia lentis, a Latin term for lens dislocation, brittle cornea syndrome, extremely rare. I'll be honest with you, all of your audience, I've never seen brittle cornea syndrome, but very thin cornea prone to rupture. So unusual ocular problems requiring surgery in childhood and young adulthood would be another flag to say, these are the kinds of common things that run amongst the EDSs.
So could we break down sort of the common subtypes, such as hypermobile and the classical or vascular? And can you tell us a few more of the features of each subtype and a little about the prevalence and genetics?
Sure. So then coming back to that group of Ehlers-Danlos, of the 13, the one that is the most common and also is the one that we don't have a gene for yet is hypermobile type Ehlers-Danlos. We think it's about 1 in 500. It's actually far more common than we used to think it was. And it's being recognized more and more as the awareness increases. Thankfully, it's characterized by less of these serious complications. So they tend not to have serious eye issues, serious skeletal issues, serious blood vessel and heart issues, which is great. But they do have a constellation of pathology we can pick up on imaging and tests, but also symptoms, things they report. If you think about imaging, they can look marthanoid. What I mean by that is they can have arachnodactyly, very long fingers. They're clearly hypermobility is a definite feature, very bendy, stretchy. They can have a mitral valve prolapse on an echocardiogram. They can have mild aortic dilatation, not usually severe. If we're thinking about severe aortic dilatation, then I think about other conditions like Marfan. So they are the sort of things, and then they can look marfanoid. So long fingers, very tall, lean stature, very soft skin that's quite hyperextensible. And then the symptom profile is very broad. And I think that, you've got other people in the series who are also talking in great detail about head. So I won't go into great detail, but it comes with a constellation of, with the hypermobility they can get often fatigue, bad fatigue, bad joint pain, joints dislocating, subluxing, so partial dislocations. And gastrointestinal and neurological problems that go with it. So that's the heads group, which is the most common group. And then the other ones, then we step down into things that are like 1 in 5,000, 1 in 10,000, 1 in 50,000. So classic Ehlers-Danlos would say probably 1 in 10,000. And that is like heads, but they tend to scar very badly. They have what's called cigarette paper scarring. So it's very thin scarring of the skin. You can almost see through the scar. And vascular Ehlers-Danlos is sort of the prototype of the nasty condition, the one that causes people to die suddenly. Their skin's almost translucent. They're the kind of people you see their veins through the skin. The skin across the face is very tight. They've got a pinched nose. We call it a pinched facies. And they've got very brittle connective tissues. So actually the other EDSs, the 12 genetic ones, can mimic hypermobile EDS. This is the key point, is that hypermobile is very common. Thankfully, it's not serious in terms of life-threatening stuff. But the other 12 can mimic it. And sometimes even for me, I can't. And I tell most of my patients, I can't be certain that I'm missing the others because there's a lot of overlap. And so you do the genetic test to rule out the 12, and you're left with the 13th, if that makes sense, because there's so much overlap.
But it's the 13th or the hypermobile, or HEADS as you call it, that we don't have the genetic test for, that is the most common one.
Correct. And yet it is a connective tissue disorder, and we know it is from, lots of, I won't go into the details, but if you look at biopsy studies and symptom studies, you look at it from the symptom point of view as well as pathology, that it is a definite connective tissue disorder, even if we don't know what the gene is. But it's part of the spectrum, even though we don't know which specific gene it relates to.
So, Kunal, with a condition such as vascular EDS, how can we try and get an early diagnosis, and what are the important management principles in terms of sort of pregnancy and lifestyle, medical, surgical management, given the risk of sudden death?
So the first thing I wanted to highlight for GPs is that even in 2025, the condition is very difficult to manage, even in a quaternary centre like the Victorian Heart Hospital. So it's a difficult condition to manage. And the second is that the spectrum of the condition actually is quite broad. So I'll give some practical examples. I've seen patients where a 65-year-old lady is diagnosed with vascular Ehlers-Danlos after her 32-year-old son suffers a dissection, an aortic dissection, and makes it alive. And we do a gene test in the son. He has it, and then we retrospectively then evaluate the mother, and she has it too. They both carry the same gene pop. Why she got lucky, why she had 3 kids, normal vaginal birth, nothing happened to her, I don't know. But the fact is, she definitely has the condition. And when you examine her, she looks very much like her son, not just because she's his mother, but in terms of the genetic condition, the translucent skin, the pinched faces. So clearly, there are people out there, therefore, who are living through that risk period that, the high risk period is thought to be 20s, 30s, women of childbearing age, because that's what's reported in literature. Women uterus rupturing, dying during pregnancy, which is real, it does happen, but clearly it doesn't happen to everyone, and so we don't have a good risk estimate on what that risk is. Then what are some practice points? Really, if you have vascular Ehlers-Danlos, we basically discourage you from bearing your own children, strongly discourage you. It's not a contraindication. No one's going to stop you if you want to do that, but we go in clear-eyed saying there is a very well described risk of you plus or minus your baby, your fetus dying during pregnancy, and we actively discourage them from having children, irrespective of what other things we do, blood pressure management, echocardiograms. We just discourage it because in some respects it's an uncontrollable risk. I don't know if that's going to happen, when that's going to happen. Then outside of pregnancy, we ring fence these people by putting in very strict safeguards to try and protect against arteries tearing, bursting, rupturing. What does that mean? Practically, it means strict control of blood pressure. It means that every procedure, whether it be as simple as a skin biopsy, all the way to colonoscopy, all the way to laparotomy, is considered very carefully. Because surgeons report, and it's written up in literature, that the tissues are very friable. They literally fall apart under the surgeon's suture. So is it worthwhile to go in there to do what you need to do? Think twice before you do that. And if you're going to do that, be prepared with whatever you can to reinforce those tissues, because they're so soft under the surgeon's hands. Those are the kinds of practical things we do. And then if we identify one person, back to that example of mother and son, we can then go identify other people in the family who might be carrying the fault. So one person might then prevent other issues in the family.
So should EDS be something we'd consider in general practice if we'd performed a skin excision and it just didn't heal well because the tissues are fragile and friable? Is that potentially another pointer for us in general practice to be considering a diagnosis like this?
I think so. I think that's a very practical point. You have a patient who's got very delayed wound healing, poor wound healing, and you haven't got another good reason. You and I both know there's lots of other steroid use and autoimmune disease, all that stuff's all still relevant. But if you can't find another good reason why this patient's skin biopsy, the stitches keep falling apart. The surgeon says I have to go back 3 times because the stitches just come out. The wound isn't healing. That is a trigger to say, could this be an inherited connective tissue disorder in the realm of Ehlers-Danlos? Absolutely.
Okay. So again, reiterating with hypermobile EDS, which is the most common subtype, there is no genetic test yet, but could you please explain with, say, classical and vascular EDS, again, back to the prevalence and when we would think about genetically testing, and in general practice, how do we do that? Does that need to go through a genetic service? Is it a test that we can order just through our local pathology company? So what would be your approach to who to test and how and when to test?
Yeah, so then some practical points. And by the way, a general practitioner can indeed order an EDS, and I'll talk through that. There's nothing precluding a general practitioner from ordering it. It's just that there's no Medicare funding for it. So if you write on a pathology form and send them off to your local private pathology service or public pathology service, they'll probably send a bill to the patient if they have a gene test on offer. So first is there's no Medicare rebate, and so the testing is funded either privately, meaning patients paying, or state government services around the country. Genetics clinics have a pool of funding from the respective departments of health to pay for that testing. The second thing is not every laboratory even does the gene test. So I'm in Melbourne at the moment, Rebecca, for example. Melbourne Pathology may not even offer the gene test. So they would ask me, okay, you want to do the gene test, but we don't do it. So where do you want me to send that sample? Because we don't do that test. So there's some practical things. Now, if you are suspecting that someone has classic and vascular, and again, we come back to those key features, very bad, unusual scarring, a family history or a personal history of aneurysms, dissections, women dying unexplained, or men dying unexplained, I would suggest you refer them either to a private or a public service, because that's where the testing can be performed, B, the testing is funded, right? And C, in a proper service, we evaluate for beyond EDS. So in a genetic service, EDS is, so now if I've drawn the picture of Ehlers-Danlos as a group of connective tissue disorders that are genetic, that is one group of genetic connective tissue disorders. There is also Marfan syndrome, which is very similar to EDS, but it's not in the EDS group. It's right next door if you want. Marfan and Marfan mimic conditions, which can look like EDS, and a genetic service will do all of that. They'll say, okay, we are not agnostic, but we'll take a broad approach. Which connective tissue disorder we're looking at, and then accordingly we build a genetic test to target that. So do we just include the Ehlers-Danlos genes in our test? Do we include Marfan syndrome in our test? Do we include beyond that in our test? So we customize the genetic test, whether we look at 1, 10, 50, 100, 20,000 genes, even in what's called exome sequencing. And all that, we can do it through a public service. Even in private, if patients are happy to pay, you can do it. But yes, I think that it would be very difficult for the GPs to diagnose it because you don't have the funding for that kind of testing.
If we were to refer through a private pathology service who was able to do, say, EDS genetic test, do you have any idea what that might cost a patient if we did take that path? Perhaps there's a long wait to get into a genetic service, or someone's happy to pay privately. How would we counsel them about the potential cost?
Yeah, so rough cost, roughly 1,000 to 2,000 Australian dollars is what they would pay. Of course, if a GP wants to do it, and in fact, I have had patients for whom the GP has requested and done a very good job, and the result is exactly, and the test is what I would have ordered too. So it's not like it can't be done. But I would caution GPs to be careful, because when you order a genetic test, you've got to specify to the laboratory what you're looking for. If you write Ehlers-Danlos, there are 30 key Ehlers-Danlos genes. But if there are some features of Marfan syndrome, then you might want to include other genes on top of that. And the standard off-the-shelf panel, we call it, many laboratories offer a suite of panels, an offering. They can say you can pick a blindness gene panel, you can pick a deafness gene panel, you can pick an Ehlers-Danlos panel. They've pre-curated the set of genes that will be looked at, but they won't look left, they won't look right, they'll just look at these genes unless you specify, I want to do this, that, or the other. So if there are features that point towards other connective tissue disorders, then they will not be covered in an off-the-shelf panel. And second, if the family history is of something else, what if the auntie's got unexplained kidney failure, or they had a baby that died of macrocephaly and a large hernia, and they want to know what else could be happening, that stuff won't be covered. So the benefit of going to either a public or private service is that we could evaluate properly, I suppose, more thoroughly. So yeah, I think that it's okay. GPs can do that. It's just that you may not be covering all the clinical questions you want answered.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
So the message I'm getting is that if we suspect it in a patient because they have joint hypermobility or hyperextensible skin or tissue fragility or recurrent wound breakdown, or they've had some sort of like a colonoscopy complication with a perforation where you think, well, that's unusual. And now we're thinking about connective tissue or Ehlers-Danlos, that really it's going to be appropriate to send them to a genetic service so that they get the appropriate panel of tests done to
Correct.
identify is there a specific genetic variant that is
Perfect.
involved
Yep.
here. And then so if that has been detected on genetic screening, what is your approach then in terms of informing them of the diagnosis, but also beyond that, sort of risk to family members, heritability, pre-pregnancy planning, and so on?
Yeah, and this is a really important point. We, in a genetic service, seeing a geneticist or a genetic service does not constitute having a genetic test. And I say it like that because in Australia, at the moment, there are significant implications for life insurance and similar types of insurance products. They're called individual risk-rated insurance products: travel insurance, life insurance, income protection insurance. Those things at the moment, those companies, there is no law prohibiting them from discriminating against an applicant based on a genetic result, right? So seeing a service does not constitute having a gene test, but signing a form and doing a cheek swab and doing it actually constitutes having a test. So what we do in a service is we do a lot of what we call pre-test counselling. We talk about, essentially, are you ready for this possibility that we are going to pick up something maybe quite serious, nasty, could be passed down to your children, could be in your sister, could be in your nieces and nephews, could mean you could never play the sport you want to play because you're an avid soccer player or footballer. I see that all the time with the basketballers that I see who have Marfan, because of course every basketballer is 7 foot tall. And so therefore, and the question comes up, they all look tall and lanky. Not all of them do, but many do. After that, I forget his name, the basketballer in the NBA who had to pull out of the NBA in 2014 because he was diagnosed with Marfan, but he was diagnosed because he was whilst he was playing the NBA, right? So that question comes up and we try and prepare them, insurance implications, personal implications, familial implications. And then if they say, yes, no, I think this would be helpful, then they sign a form, they do a test. And so that's really a two-step process. We essentially see patients for 2 appointments as a minimum, sometimes 3 or 4. They want to talk about these issues, talk about what it means for their children. But minimum 2 appointments, pre-test, do a test, and then post-test. And then after test, then if we find a gene fault, a spelling mistake, a mutation, one of these genes, then we offer family to come forward and say, now there's a genetic condition, we'd like to see you and do the same thing again. Would you even want to know? Because just because there's a condition, right, Rebecca, it doesn't mean you want to test. I have many patients who say, good to know my uncle had Marfan and died suddenly. I'd rather not know. That's not what I want to do. I love my camping. I love traveling. It will ruin my life if I know about this condition. Yes, I appreciate, Kunal, you showed me an image of an aorta tearing and people dropping dead suddenly. That's not what I want to know. My kids can know when they want to. I don't want to. And that's autonomy. I've informed you. You've made an informed decision. So we don't force a test on anyone, and some people decline it, but most people opt for the test.
What happens if they learn this diagnosis before they have children? Could they go ahead and do IVF with PGD without knowing their own genetic result if they're a suspect for having a connective tissue disease?
Yeah, interesting. So let's say, we can't do that for hypermobile EDS because there's no gene for it. But let's say there is a family history of Marfan or one of those 12 other EDSs, let's say. And we know that what the fault is by obtaining records on the uncle, the aunt, the cousin, whoever it might be, the sister. And the patient says, I don't want to know my own result, but I want to test. It's very problematic. Is it technically possible? I think it is technically possible. An IVF service can obtain the records on the sister, the aunt, the uncle, whoever it might be, and say, we are blinding you to this, but we can tell you which embryos carry the fault and which not. But then by revealing that some embryos carry the fault, some do not, you are revealing that the person in front of you has the fault, right? Because you've said you've got 10 embryos, Mrs. White, 5 of them carry the fault, 5 don't. But that means the fault was in the mother or whoever it was, I didn't diagnose you, but by virtue of only half the embryos having the fault came from somewhere. It came from parents. So it's almost impossible to blind the parent from that diagnosis, even though you may not put it on a piece of paper, but they will know that the diagnosis exists. So very tricky situation. There's no right answer there. But I think in most situations like that, we'd probably convince the parents, like, if you're really considering this, then we probably just talk you through why you are so hesitant to be diagnosed yourself. And perhaps I can help you with that, because once I do the gene test in you and you know that result, it makes it so much easier to do PGT. Yes.
So if someone did test positive then and before pregnancy, you said before that you would counsel them about the risk of having a pregnancy, but they could perhaps elect to do IVF, PGD, and then use a surrogate with unaffected embryos, so they can still have children.
Absolutely. Yes, people with vascular Ehlers-Danlos, they can have a surrogate pregnancy. Absolutely.
All right. So we've talked a fair bit about the genetics and genetic testing then. Are there any other sort of environmental or epigenetic factors that might come into the expression of these conditions?
Massive. There must be, Rebecca, and I'm going to be as honest as I can. I don't know what all these factors are, but there must be, right? Because why is it that, coming back to the vascular Ehlers-Danlos family, why is it that the mother had those 3 babies, no problems, and her son, is sitting there on the edge of the tennis court? He wasn't even playing tennis, and all of a sudden dissects his carotid artery, just sitting there. Why is that? So there clearly must be environmental epigenetic factors. Lots of research obviously happening in the area, but I don't have anything beyond the standard things that you in your practice and me in my practice, the standard cardiovascular risk factors. Of course, cigarette smoking on top of vascular Ehlers-Danlos will just be an absolute, recipe for disaster. So of course we'd want to focus on those things, but would I be able to highlight additional environmental factors beyond what we already know? I can't at this point.
Yeah. And again, back to hypermobile EDS, it stands out because there is no single genetic cause yet identified, and yet it's the most common of the subtypes. Where's the research at with trying to find the specific genetic cause of that subtype?
Yeah, the research is progressing. So there is a particular laboratory, I think it's in North or South Carolina in the United States, that's the leading laboratory worldwide for EDS research. And they published a paper, or they put a paper forward for publication last year, where they think they've identified a gene that may be relevant. It's all at the moment research and putative and postulating. It looks promising, but I think we are still a while away yet. It's going to remain for years, for the foreseeable future, a clinical diagnosis, or one that you make after you rule the other 12 out, essentially, which is really what you do. In the diagnostic criteria, for anyone who's seen it, right at the bottom it says someone, whether it be a geneticist, a GP, a rheumatologist, a physio, whoever it might be who feels comfortable, has ruled out the monogenic single gene 12 Ehlers-Danloses before you diagnose hypermobile Ehlers-Danlos.
I suspect that for a lot of patients, it takes quite a long time to finally get the diagnosis, and they may have presented along the way with recurrent ankle sprains or joint subluxations or poor wound healing or whatever those sort of features may have been. Can you talk to me from your perspective as a specialist seeing these patients? What's that diagnostic journey typically like for patients?
I think it is typically painful for them, from the tears that I see in the room when we make a diagnosis in our clinics and tell them, it wasn't in your head, this is a real thing. There's a reason why, your kneecap popped out 6 times and you were in the sick bay at school every other week, because you suffered a sprain that, doing nothing, essentially walking in the playground. And for how many years you suffered the pain that you have in your joints, and why your wounds just take longer to heal. It's decades, A, it's painful, B, so I think if I could take this opportunity to highlight to GPs that if you have patients who have these red flags, which we'll go over again, not just for the rarer forms of EDS, but also for hypermobile, don't hesitate to engage your service, because patients are really grateful for it. The fact that they've been properly evaluated for it. I mean, I've got patients who I've seen, and I'm diagnosing them with hypermobile EDS in their 20s, who've been through 2 decades of mum taking them in and out of the doctor. The mum's in the room crying too, saying, I can't believe there is a name to this condition. I was always told she just had growing pains. I can't tell you how many times I've heard that story. She's just got growing pains. And the amount of times I took her to doctors and rheumatologists and they said, I can't, she's got nothing wrong with it. It's in her head. That awful kind of, what's the word, gaslighting, that they tell me that this is what, and of course, the people who saw them didn't mean bad. This is no judgment on the specialists and GPs who saw them. This is just to highlight that they take 2 decades to be diagnosed. And if someone had thought about the condition and said, go and see someone who knows what they're talking, go and see a service that knows what they're talking about. It might have saved this patient and that family so much grief.
Again, maybe we can just highlight some of the common things that would cause us to consider this as a diagnosis, to try and avoid that 2-decade lag and the gaslighting that patients might otherwise encounter if no one thought about this as a potential diagnosis along their health journey.
Yes, of course. So I'll break it down into two groups. The first is the 12 nasty and the genetic Marfan, Ehlers-Danlos disease. They're all monogenic, meaning single gene connective tissue disorders that can look like each other and can be quite serious. So for that group, they're probably the ones that are easier to identify because they have something really bad that happens in their family history, their personal history. We're talking about severe scoliosis, severe myopia. Now, myopia, of course, I'm very short-sighted. Myopia is very, very common. So I'm not saying refer every myopic, but anyone who has a lens dislocation or eye surgery young for no good reason, not strabismus, but actually ocular pathology of the lens or myopia, retinal detachment, that kind of stuff, unexplained, not jumping out of a plane, unexplained retinal detachment, severe scoliosis, aneurysms and dissections, sudden unexplained death in the family, good swimmer uncle drowned at the beach, don't know why. That is a hallmark to say there's no good reason why that uncle drowned. Think about a genetic condition like Marfan syndrome. So those are the red flags for those the ones you can do a gene test for. And then for heads, I think if you see patients who are hypermobile, so they are able to extend their joints beyond the normal range of motion, they have a history of joint partial or full subluxation dislocation with minimal trauma. And any of these features, unusual delay in wound healing, and a nexus of symptoms that you can't explain otherwise, gastroenterological problems, neurological problems, pain and fatigue, that, if I could draw a picture, that these patients have symptoms that I'm putting together in one name, which for years prior, people have been trying to look at as individuals. So if you have patients and clearly they would be in your rooms because they're seeing 5 different people and you're trying to put the picture together. And so I'm saying that if you have these patients who are hypermobile, joint issues, and then they have multi-system problems that no one else can put a handle on, think about hypermobile Ehlers-Danlos for them.
And then if they're able to get the diagnosis, which I hope that we're now better informed to be able to get that process started, how can we best support them as GPs in primary care with sort of the challenges they may face in managing their condition?
So to aid in that, there are several organisations that are working in this space, but one in particular is the Connective Tissue Disorders Network of Australia, which I know you were in touch with. They are a patient advocacy group, essentially, and I sit on their medical advisory committee. And the sole aim is to improve better pathways of care for these patients. And I'll give you the link so you can put it in the show notes, Rebecca. So I think that the reason for such organisations is because the care of patients with EDS is fragmented. It genuinely has been for decades. Even the ones you do a gene test for, even those, they're fragmented, let alone hypermobile EDS, for which there's no genetic test and the diagnosis can be more difficult. So I'm pointing GPs towards resources that may help them. Well, I'll give you a few that if you could share with the GPs. But I would say that we need to get that patient linked in with an allied health practitioner who understands EDS. As a caseworker, as a coordinator, and there are several of those now around the country, not just in Victoria, people who have put their hand up and said, I'm EDS aware, / I even have EDS myself. I know how to help these people. Come send them to me, and they're in our networks, which I'll share with you. So I would suggest to GPs that you're not alone in this. It's difficult, but and find them an allied health practitioner. We're talking about a physiotherapist or an exercise physiologist who is EDS aware, who can then guide that. I think a geneticist like me makes the diagnosis, but I don't really have to be involved in their care ongoing. Neither is a genetic service. We're about putting the picture together and saying, this is the name to your condition, but then they need the care through an allied health practitioner with the expertise in the area. So that's what I think would be beneficial.
So just to reference, again, one important resource is the CTD Network of Australia, and then try to find an EDS-aware allied health practitioner would be useful.
Absolutely, yes.
All right, Kunal, we've certainly covered a lot. I'm wondering if you can sort of summarise any important takeaway messages then for the listeners.
Look, I think takeaway to point number one, go easy on yourself. These are conditions difficult to diagnose. And if someone comes to your room and they've just finished a diagnostic journey in one of my clinics, it wasn't your fault that it took 20 years to get there. It was a cascade, a Swiss cheese model, number one. So be easy on yourself because they're quite rare conditions. They're not like our standard stuff we deal with. I'll give you some key red flags that you must never ignore and think, this is a flag's gone up. I must think about referring this patient. His personal or family history of unexplained aneurysms or dissections, unexplained sudden death, severe skeletal ocular complications, very bad wound healing. And the younger people, it can be older too, but younger people, adolescents, 20s, 30s, hypermobile, lots of joint issues and multi-system problems that don't fit into one easy basket. Think about hypermobile EDS. Know that genetic testing is best done through a genetic service, even though you can do it, but I think it's better done through a public or a private service. And that we can do a lot for these patients now with allied health practitioners who know the space, and also on the vascular side in places like the VHH and the Alfred where I work, we can effectively prevent many complications, not everything, but we can do a lot more than we used to.
Fantastic takeaway messages. Dr. Kunal Verma, thank you so much for joining me on today's Health Ed podcast and for sharing your expertise and insights on a very interesting topic. Even though it's rare in general practice, it's obviously an important one not to miss. So thank you so much for your time today.
My pleasure. Thanks for having me.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.